Welcome to the Obesity Podcast, your dedicated platform for expert insights aimed at enhancing obesity management, one episode at a time.
Welcome to this new episode of the Journal Club by the Obesity Podcast. My name is Imane Eddbali, Professional Education Manager at Johnson & Johnson, Europe, Middle East and Africa, and I'll be your co-host.
And my name is Marco Bueter. I'm a bariatric surgeon based in Switzerland, working at the University Hospital in Zurich and also in a smaller public hospital in Männedorf, close to the Lake of Zurich. And in this episode, we would like to talk to one of our close friends, Professor Paulina Salminen from Turku in Finland. And we would like to discuss today her 10-year data from the randomized clinical control trial that has been published in JAMA Surgery in August 2022. And the official title of that paper is Effect of Laparoscopic Sleeve Gastrectomy versus Roux-en-Y Gastric Bypass on Weight Loss, Comorbidities and Reflux at 10 years in Adult Patients with Obesity, the SLEEVEPASS Randomized Clinical Trial. Hi, Paulina.
Hi, thank you very much for the invitation to this journal club.
You know, we have to thank for you taking the time to discuss this important paper with us. So, why is this paper so important?
Well, of course, I'm a bit biased to address this.
You mean as
question
the first author of that paper?
Being the first author of the paper and being the study group leader and the PI of that study. So I may be a bit biased, I have to admit up front. But I think one of the reasons I do agree on the fact that it is important is that it is long-term data. It is 10-year data of a randomized control trial that has a very good follow-up at 10 years. So we're actually able to believe the results because we were able to have approximately 80% of the patients for follow-up at 10 years. So that is really a good follow-up rate because I think within the metabolic bariatric surgery field, one of our problems is the lack of high quality long-term data. And as obesity is a chronic disorder and we do have procedures that may have actually some adverse events later on at 20, 30 years even. So we should really be focusing on having the long-term data as we need to have a treatment for the chronic disease that actually works at long-term follow-up. So due to both of these issues, I think the long-term data availability is something that there is a lot of room for improvement in that within the metabolic bariatric surgery field.
I absolutely agree, and this is one of the reasons why we specifically picked that study to be discussed in the Journal Club. If you agree, maybe we should start with discussing the trial with, talking a little bit about the methodology. Can you let us know what was the primary endpoint, how many patients were included, what was the baseline BMI of the patients being included?
Yeah, the primary endpoint is percentage excess weight loss, so percent excess weight loss. And at that time, it was actually that was the parameter to be used for surgical metabolic bariatric surgery trials. And of course, at this point, we know that that's not the most optimal way of addressing weight loss. Our primary endpoint was also scheduled to be addressed at 5 years, and that was the JAMA paper in 2018. So this was a predefined long-term analysis of this RCT, but it was a secondary analysis because the primary endpoint was at 5 years. So that weight loss is the driving force, so that's why it was chosen as the primary endpoint. Our trial is an equivalence trial, and I've said this a few times at congresses because when you have an equivalence trial, you need to set the predefined equivalence margins, and that is very tricky, especially because when we started doing this RCT, and we enrolled the patients from April 2008 to June 2010, And as you remember, in 2008, really, there were not that many sleeves performed in the world. So we really had no data to actually base the predefined equivalence margins on. So the data was very limited. So these margins had to be set somewhat arbitrarily and kind of based on clinical idea. And that was actually one of the issues of that study design. So we had 240 patients that were randomized to either sleeve gastrectomy or one gastric bypass from 18 to 60 years. And the median BMI at baseline was, I think, let me see the median. It was
45.9.
It was 44.6 in sleeve and 40.6 for the whole study group. So very similar, almost 70% female. So very similar case mix as a lot of the metabolic bariatric surgery papers have. We did have a baseline type 2 diabetes prevalence that was much higher, for example, compared with the SLEEVEPASS trial, which is very similar and conducted during the same time frame. But those are the basic details for the study.
Right. And what was found, after 10 years? In the title, you specifically talk about weight loss, comorbidities, and reflux. So let's start with the first. If you compare the 10-year data, could you find a, statistically significant and maybe also clinically relevant difference in weight loss between the two procedures at that time point?
Well, again, this has to do with the initial study design. So at 10 years, the percent excess weight loss, it was greater after one-wide gastric bypass.
Right.
And the procedures were not equivalent for weight loss.
Right.
They both resulted in good and sustainable weight loss. But when you look at the weight loss outcomes, there is the similar situation as in the 5-year paper. So the confidence intervals are not within the limits based on the predefined equivalence margins. So even as it is greater, they're not equivalent, but then it is really tricky to draw the equivalence design conclusion. But in real life, the percent excess weight loss, it was a bit better after one-wide gastric bypass, but they both resulted in good and sustainable weight loss.
Right. Okay.
From a comorbidities perspective?
Comorbidities perspective, it was very identical to the 5-year data. So, and I have to remind you also at this point, because for none of the comorbidities, this trial was really not statistically powered to detect differences. Especially, I think this is important in type 2 diabetes remission. There was no difference between the study groups. And I have to point out that because at 5 years, we did do merging of the 2 RCTs on an individual patient data level with the SLEEVEPASS and the SLEEVEPASS. So our patients actually had a very long preoperative type 2 diabetes duration already. So that really affects the type 2 diabetes remission rate here, but no difference between sleeve or bypass, no difference between obstructive sleep apnea, and no difference between dyslipidemia. Bypass was superior for hypertension, but this was based on the definition of medication use. So no objective hypertension values or addressing whether they were actually normotensive. So, but it was based on the medications. And I think that's also important when you look at different definitions, that how are these things defined? So what is actually remission?
Yeah. How, the diagnosis is defined at the baseline and how you define remission, right? Both.
Yes. So you really have to look into, otherwise you're just comparing apples and oranges.
Yeah, right. We'll address that later on, because I know this is, one of the other projects that is close to your heart, making results between, different clinical trials comparable. And the final point, the final focus in the results of this paper is the effect on reflux, because, for our, followers and listeners, there have been, lower level of evidence data suggesting that the sleeve gastrectomy is associated with a higher, incidence of reflux disease leading to esophagitis, and even, and that's what I meant with the data, with the Barrett esophagus.
Which is a big claim.
Yes. So how were your results in that aspect?
Well, going back to this other data showing up to 17% of Barrett's after sleeve gastrectomy, so that really got us worried.
Yeah.
And as said, we designed the study in 2007 and started enrolling patients in 2008. So at that time, we really did not realize, or nobody realized, that GERD would be such a major issue after sleeve. And we did have, as an exclusion criteria, we did have severe GERD and large hiatal hernia, but that's it. No more standardization or really specific definitions for that, which I'm really, again, if I would go back, I would do it very differently. But this is how it was. And that's why we actually had to make an amendment for the 10-year follow-up, because I wanted to do an upper gastrointestinal endoscopy on all of the patients. All of them underwent that preoperatively. So we know that they did not have Barrett's. So we wanted to do that again at 10 years. And we were able to do it for 77% of the patients, which I think is very good. And you do see that I think the issue with sleeve gastrectomy really is reflux in a way of symptoms. And of course, we did have, when you look at esophagitis, so an objective finding of reflux, it was much more prevalent after sleeve gastrectomy, so 31% versus 7%. But when you look at Barrett's esophagus, which actually the main concern, there was no difference between de novo Barrett's at 10 years. So it was 4% after bypass and 4% after sleeve gastrectomy, and they were all short segment, non-dysplastic Barrett's. So no difference there. So I think that's the key point, that you do have to recognize that you have more GERD symptoms after sleeve gastrectomy. You will have esophagitis. It will be much more common after sleeve gastrectomy, but apparently, at least a 10-year follow-up rate, there was no difference between Barrett's esophagus, and the rate was much, much lower than in the other cohorts. Yeah. But it's going to be interesting to see what happens in 20 years.
Yeah. So potentially the progression that was initially, let's say, raised as a red flag is not found here.
No, it's not found here. And then you could argue that what happens at 20 years, because you do have esophagitis, so that could lead into to Barrett's, of course. But we will be doing the gastroscopies again at 20 years. So we will see whether there's progression, because if there's not, I don't really see that this is going to be an issue. And I feel that even though you look at just plain Barrett's surveillance endoscopies, so really it is something that I don't see as a major concern. But I do think that you have to really be aware when selecting patients that actually have GERD, or they have a finding associated that could actually lead to de novo GERD after sleeve gastrectomy. So that is a clinical issue.
And we'll make sure to invite you again in 20 years and 10 years on our
it's going to be
to give us the results.
Yeah.
Speaking about safety also, were there differences if it comes to, complication rates after the two procedures at 10 years, reoperation rate, for example?
Reoperation rate was 15.7 for sleeve and 18.5 for Roux-en-Y gastric bypass. But for this, I have to say that, again, I think both reoperation rates are affected by the limitations of the study design and conducting the trial, because for the Roux-en-Y gastric bypass, we did not close the mesenteric defect. So the majority of the reoperations were actually real laparoscopies to see whether you actually had an internal hernia. And for sleeve gastrectomy, the majority of the reoperations were conversions to Roux-en-Y gastric bypass based on reflux. And again, it is impossible to say how many of those could have we avoided with having a better inclusion-exclusion criteria to begin with. But I can just say that, of course, some of the patients would not have really been randomized if you would have more stringent criteria that we currently use for sleeve gastrectomy. So, but no difference between the groups, but the results for reoperations were very, very different.
Right.
And of course, looking at the weight loss trajectory, because of course then, and we have to remember to use the correct terminology. So when we have recurrent weight gain, which may happen after any of the procedures, but for sleeve gastrectomy, of course, looking at some other data, it may be more prevalent after sleeve gastrectomy. And that's going to be interesting to see with the weight loss trajectories like 15 and 20 years, because at 10 years, the weight loss trajectories at each of the time points are very similar. So the difference between the procedures is very constant. So no major differences there. So it's going to be interesting to see what happens in 15 and 20 years.
Absolutely. And congratulations again for performing such a great study. And we would like to close this episode with the final question, how these data are currently implemented in, current practice. But because if we look at the published data so far on, let's say, global numbers of, procedural distribution, I think the sleeve gastrectomy is still the most frequently performed bariatric procedure out there, with somewhere between 40 to 50%. And the gastric bypass is, if I'm not mistaken, somewhere at 25 to 30%. That's actually not supported by the data, right? I mean, you would expect something like 50-50 balance, right?
You would. And I think this is a good example of really waiting for the data to be implemented. I would say that we will have the SMBOSS 10-year results, which are still not out there. So I think this is another piece in the puzzle that would add to the literature and evidence-based medicine. Again, implementing the results of a clinical trial to clinical practice takes some time. So I think hopefully we will in a few years see a bit of a decline in the sleeve gastrectomies. I do think it is a good procedure for some patients. So you really have to start thinking about how to tailor it and how to have comparable results between the different trials to assess that what would be the optimal procedure selection for that specific patient. So we do have two good procedures.
Well, thank you very much. That's a very good closing remark for this episode of the podcast. We thank you very much for your time and sharing your insights for your great study. Congratulations again.
Thank you.
And hope to speak to you soon.
Yeah.
Thank you. Thank you, Paulina.
Bye.
Thank you, Marco. We'll see you on next episode then. Bye, everyone.
Stay in touch. Bye-bye.